Yep, all good here.
I saw that there's some areas that have some nasty weather.
Oh yeah, we got
Yeah.
hit with snow like crazy last night and then it disappeared this morning.
Oh, wow. Guess there were still some closings.
Oh yeah, a lot of schools are closed here.
I think Pennsylvania got hit again too. So,
We got hit with like an inch and a half of snow or something like that.
yeah, crazy. Like, come on. We can be done with the snow now. Everybody, I'm sure, is ready for spring, summer,
Yep. Like a few
something
days ago we
warmer.
had nice weather and now it just goes the opposite.
Yeah. Great. Still have a couple people getting ready to join. Tasha, are you there? Martha? All right. So we only have one chapter today. Um, Alamatu, you can't be in your car. You're muted.
Yeah, I just got to the campus, so I'm leaving.
Okay. All right. So we have one chapter today. It is on nursing theory, research, and evidence-based practice. So we'll go through this chapter, um, and then we'll do pull up some practice questions and do some practice questions. Um, so nursing theory. I will share my screen. Give me one. Okay, so share my screen. Ugh. All right. Well, my computer's doing this morning. All right. So nursing theory. So there are numerous theorists out there. If you Google nursing theories, you'll come up with a nice long list. Nursing theories dot, I think it's nursingtheories.org is a really good site. You can look at and get an overview of nursing theories, different nursing theories. Um, but again, there's lots of nursing theories out there. Some of them are the basis for curriculum development as well. So nursing programs will often use nursing theories as a basis. In addition, they also provide a basis for research on the effectiveness of nursing care. And so the three concepts that are important to nursing, the person, right? The recipient of the care, our clients, people that um, we're taking care of. B, health, right? Or number two, health, which is the goal of nursing, right? Goal here is to try to restore our clients back to their previous state of functioning, right? Or as close to their previous state of functioning as possible. And then the environment, the setting where nursing care takes place. And we know that nursing care can take place in a variety of settings, right? In hospitals and clinics, at home, long-term care facilities, right? So those are the three basic concepts that are important to nursing. And why do we discuss nursing theory? So as you progress through your education, go back and get your RN. You will go back and you will even study more nursing theories. Um, because like I said, they are a framework for nursing education in some cases too in as well as clinical practice. Um, and so if you decide at some point too, when you're in your nursing career, you want to go work and do research, right? Then you'll obviously come in contact with nursing theorists as well. I don't know how many people like to do research. Some people enjoy doing research, other people do not. So, Florence Nightingale. Everybody should know who Florence Nightingale was. So Florence Nightingale, back in the 1860s, right, she was the first to emphasize the environment. So things like ventilation, warmth, noise, light, cleanliness was a big one, right? Why do we wash our hands in between our patients? So she is considered the first nursing theorist. She believed the environmental issues influenced the course of illness, right? She also saw the nursing role as separate, right, from just the person to do the doctor's bidding, right? She was also the first to collect data and use evidence to make her clinical decisions, right? Hence, like, why do we wash our hands in between our clients? Um, and she, came to find out that, that warm, clean, well-lit environment with minimal noise was, resulted in a decreased death rate for she served during the Crimean War. So she taught her nurses, right, to keep the environment clean, warm, um, and, with minimal noise, to have those better outcomes for her clients or her patients. You also should be very familiar with Abraham Maslow. He wasn't a nurse, but he was a psychologist. But his human needs theory, right, we use it within nursing as well. And so his theory states that certain internal, external, physical, and psychological needs are common to all people, right? And he has them arranged in that nice little triangle or that hierarchy. Um, Unmet needs create tension, which motivates the person to react to meet the need, right? So, what's at the bottom of Maslow's hierarchy? What are the basic needs that everybody needs? What are those basic needs?
Making sure that their psychosocial needs their psychological needs are met, like their housing, food, water.
So psychosocial needs are met.
Yes, yes, like the love, belonging.
So
I
those,
want to
yeah.
say
So
self-esteem,
the basic
the
needs,
basics.
oxygenation, nutrition, elimination, right? Safety, rest, um, hygiene, right? Those are the basic needs that everybody has. And so if I don't have food or water or, pain relief, right? Then that is going to create tension, right? It's going to motivate me to try to meet those needs, to get those things, right? And then once I have them, I'm no longer aware that I need them, okay, because the need is met, right? So that's not going to motivate me, right, to keep going there, right? Dominant needs that matter to a person can vary in life, right? So as we get older, um, as our situations change, right, the things that we consider the most important needs can change over a period of time. Then we have Dorothea Oram. So Dorothea Oram, her theory was the self-care deficit theory. Um, it has three sub-theories within it. Self-care, self-care deficit, and the nursing system. So self-care goal that is directed towards a safer environment for life, health, and well-being, right? So, generally speaking, people learn to respond to health cues in ourselves, right, as well as the environment as a way to maintain our personal health. Anybody that comes into our care, right, has some sort of a self-care deficit. All right. So personal care does not meet therapeutic self-care demands. So we don't recognize or we don't know what to do in regards to a self or a potential health situation. So let's say, you have the flu, you have a heart attack. So whatever the reason you're seeking healthcare, for whatever reason, you're unable to care for yourself. So that results in a self-care deficit. All right. So we seek healthcare assistance. So that nursing system, the nurses empower the client through their interpersonal relationships, right, to help meet their self-care demands, right, regardless of the situation. Um, and so, that's where that holistic care comes in, or in some cases, we just provide that supporting role. But again, anybody that comes into a healthcare system has some sort of a healthcare deficit, right? They're not able to meet their self-care demands, and so they need nursing assistance. And so that's kind of how her theory is set. Um, it's also Dorothea Orum's theory is also concerned with growth and development needs, as well as the physiologic and the psychological needs of the client as well, right? And so that's how we use our nursing process, right? And then we choose those, individualized interventions, right? So that we can help the clients meet their outcomes. Has anybody ever heard of any of these um theorists before?
Just the Maslow's.
Maslow.
Maslow's, everybody has heard of Maslow's. Um, all right. Um, Madeline Lennon. So a funny story. I'm going to I'll tell you guys a funny story about Dorothea Oram. So, we went through our LPN program, my LPN program. We didn't have a whole lot of nursing theories. And not even really in the RN program, except for maybe some, obviously Florence Nightingale and Abraham Maslow. Um, when I went into my bachelor's program, we had to take a nursing theory class. And so one of the assignments was on Dorothea Oram. But we hadn't covered her as far as like the information in the class yet. I had no idea who Dorothea Oram was. Like I had to write a whole paper on her. I didn't know her first name. The paper just said write a paper on Oram's theory. And I'm like Googling, I had no idea what I was doing. And I wrote this paper, and the instructor basically was like, okay, I don't know what you're writing about, but here's the information. So I ended up having to rewrite the whole paper, to try to figure out, or after I figured out what I did wrong, I was like, I felt so dumb. I was like, okay. So I had to dig deeper into my books a little bit more and really learn about nursing theory. But there's a lot of nice theories out there. Um, that are interesting, that you can apply. Another one that, I don't think we really talk about it here. We'll talk a little bit about it here, but another big one will be Watson's theory. Like I said, we'll talk about it a little bit here, but that's another big one that you may come across in practice. Sharad, I sent you a message. Um, so the next one is Madeline Leninger. Um, her Leninger's was had a huge interest in cultural care, and how nursing responds to people of different cultures. And so she, understanding, we've talked about cultural care and really understanding their patient cultural background, and incorporating some of that into nursing care. So when she developed her cultural care theory, she identified two kinds of care in every culture. We have generic, um, which is the home remedies that are used in care. And then we have professional, and that's the care that is provided by, nurses and doctors and other specially trained personnel. And so there's three modes to guide those nursing decisions when we're providing care. So we look at cultural care preservation, right? We've talked about this before. We incorporate, their cultural preferences within the care that we're providing, right? As long as it's safe, it's not a danger to themselves or others, right? But a lot of times when we look at this, right, it helps them to maintain health or even to restore health in some cases. Um, and so you can think of, variety of different cultural, um, remedies that people use, right, in different cultures as part of their healthcare, whether it's herbs and spices, or even different, things like acupuncture and acupressure. Cupping is another one. Um, your cultural care accommodations or negotiations. So this is another one. So when we look at it, right, like I said, right, we want to incorporate their cultural practices within their healthcare, but we also want to make sure that we're, doing it safely, lack of a better word. So I think the book provides an example of what is it? The Vicks Vapor Rub, right? Anybody use Vicks? I love Vicks. I love Vicks. Real the menthol can really help. Um, but where are you supposed to put it, right? You're supposed to rub it on the chest or even sometimes like, on the neck, right? And it helps to soothe. A lot of people put it in their nostrils. Has anybody ever done that? Put it like in their nostril? Okay, good, because you're not supposed to do that. It could potentially be aspirated and lead to pneumonia. So if we have people that want to use Vicks, that's perfectly fine, right? It's just a matter of showing them how to use it appropriately. I'm not gonna lie, I did one time. I put it like right underneath my nose. I was so congested and I was like, I wanted it as close as possible to the source. And I sleep with a fan on, just so you know, not a good combination. I put the Vicks underneath my nose and the fan was blowing on my face and it just increased the burning significantly. Then I had to go and wash it off. So just no, don't do it. Um, I really thought it would help, but it ended up doing more damage than good. So I completely understand. But like I said, I figured, and I've seen other people do it, but yeah, no, it burned, just let you know. And then cultural care repatterning or restructuring. Again, her theory is concerned with, right, respecting our cultural differences, but providing that safe environment. And so, again, it's a matter of, looking at their cultural practices, and then providing a bit, just like a safer alternative, so that they can still incorporate those. Um, and so again, her theory was really the foundation, right, to providing that culturally competent care for our clients. Rosenstock, so what was it? Erwin Rosenstock developed the health belief theory. Basically, this tries to explain why a person will or will not take action to prevent or detect illness. And so there's three different bases to this theory. So the first one that would try to explain it is that perceptions vary and may have no basis in reality, right? So why does somebody not choose not to go to the doctor or to, not seek health care? And there's a variety of different reasons, even if you take cultural care into this, or into consideration with this, right? There could be a variety of reasons. Things can be embarrassing. They don't want, to talk about private issues, right? So again, variety of reasons. Beliefs are connected to existing barriers, right? So things like cost is a big one, right? We know that cost is huge in healthcare. They may not, want to spend the money to have some of the, you know, uh, preventative treatments or the actual treatments because of cost. Um, Pain is another one. A lot of, when we think of treatments, sometimes they can be painful. And generally, one of the biggest fears that our clients have is pain, right? Or it can be inconvenient, right? I work 9 to 5. My doctor's office is only open 9 to 5, right? I don't have time to take off to go to the doctor, right? I'd rather spend my time off doing other things, right? Um, so if we can remove some of the negative aspects, the cost, the time, the inconvenience, right? Then people may be more likely to participate in those health promotion activities. Um, and then a cue to action is seen as necessary. So I really think this is actually even more so more recently, I would say within the last few years, even watching TV, listening to the radio, aside from the pharmaceutical commercials, because we all hear, about the new and best drugs. But they've really started to put some more emphasis on some of the chronic diseases. I've seen some for like hypertension, diabetes. I'm trying to think, there was another one that I saw too. Um, I was like, that's really interesting, and I can't remember what it was now. But they really put it out there. The Cologuard commercials, everybody, I'm sure, have seen the Cologuard commercials, right? For colon cancer screening, right? So they're trying to make some of these things a little bit more well known, right? Put some information out into the public as well as make it a little bit more convenient, right? So Cologuard, if you can do your colon cancer screening at home and then mail it in, right? That's a lot more convenient than having to go and set up a whole colonoscopy and do the colonoscopy prep, right? And go through the whole procedure, right? So there are different things. So and then even sometimes, so we look at that cue to action, right? The more that we put it out there, whether it's TV commercials, whether it's the radio, whether it's a news story, um, or even sometimes they call from your doctor's office, right? Like, hey, we haven't seen you in a while. It's time to come in for your annual physical or, whatever it is. That may actually, encourage someone, right, to go get those screenings done. And we can use this with the nursing process as well, right, to promote those yearly exams, the vaccinations, even wellness classes. A lot of your hospital systems will offer some sort of wellness classes about certain things. Um, and then we have Sister Callista Roy. Sister Callista Roy, she describes the recipient of care or our clients as a holistic adaptive system. So she developed her adaptation model. And there are both internal and external stimuli that affect health, right? We know that. And so she identified the stimuli as focal, contextual, or residual. So focal is something direct, right? You have a client that is experiencing pain. Contextual are other things that will affect the pain, right? So, culture can play a big part in pain, but it also could be like, what when somebody tells us that they hurt somewhere, what's the first thing that we want to do is we want to touch it, right? We want to feel it, we want to poke it, right? We want to see what's going on, right? So that, touching and feeling, right? That is the contextual and then the residual. The residual is the internal and external factors that may not always be evident. So like a memory of a previous pain, right? So I'm going to use childbirth. Anybody have kids? Anybody have more than one? Okay. So this is just, you have your child, right? Whether you choose to have, the epidural or not have the epidural, right? And while you're in labor, sorry, Matthew, I know that you might not be able to understand this part, right? But while you're in labor, the pain is pretty intense, right? You go through it, right? But a little bit of time goes by and you forget that pain, right? You forget it for the most part. I mean, you may have some vague memories of the pain, right? But we obviously, if we've had more than one kid, then we, we kind of know what we're getting into. Um, but right, memories of previous pain can affect. Some people have significant amounts of pain during their deliveries, right, and choose not to have any more children, right, after that first one. Others, like myself, I chose to have three other kids after the first one, right? And so your memory and your perception of the pain is all, it can affect your healthcare. She also identified coping mechanisms. Okay. And we've all heard of coping mechanisms before. And so there's coping methods, they're known as regulator and cognator subsystems. Okay. Or so a regulator subsystem refers to the internal effects that take place in response to what is happening internal, right? So we think internally, we can use pain, we can use anything as an example, right? So anytime something happens, you have acute pain. What happens internally when we have acute pain? What happens to our physiological system when we have acute pain? What are some things that happen? Anybody?
Would it
To
make
think
your
about that
fever go
sympathetic
up?
nervous system. What
Would it
happens
make
with our
would it
sympathetic
make
nervous
your
system?
fever?
Go ahead. Okay, fever. What else?
Inflammation.
What happens when that fight or flight kicks in? What
Bye,
happens?
Your heart rate and your respirations go up.
Right, heart rate goes up, respirations go up, my blood pressure goes up, right? So now, then that's like I said, acute pain, right? So acute pain, we're generally going to have elevation in those things, right? It's a combination of processes that occur. So it can be, chemical, could be endocrine processes, it could be even nervous system, right? And so no matter what, right, that when we look at the regulator subsystem, the body is attempting to regulate the system, right? Even though it's being affected negative, right? And that is how we have those negative feedback systems, right? The body is always trying to resort to homeostasis, right? It's always trying to get us back to a homeostatic um, place, right? Regardless of what is going on. The cognitive subsystem that's learning and processing, judging, it's all emotion, right? That's how the patient or the client uses or what the client uses to cope with what has happened, right? So pain. Pain is such a subjective experience, right? But this is, the internal, like, how are we going to deal with the pain, right? We know that this is culturally based too in a lot of ways. Everybody expresses pain differently, right? Some people are very stoic, some people are very open about about the pain that they're experiencing, right? So those are the two coping mechanisms that she identifies. Um, and then she identifies, nope, she didn't put in there. She identifies that there are adaptive modes, right, to help clients deal with situations. And so we have the physiologic, right? So, kind of what the internal stuff is. So like we were talking about the neurologic, the endocrine, um, self concepts, right? Um, which are really important, right? Our functions and how we deal with things. And, teaching patients coping mechanisms regardless of the situation is something that we are going to do, right? We want to focus on those positive coping mechanisms, right? The negative, not the negative, right? We don't want them drinking and using illicit drugs and right doing things that they shouldn't be doing that are going to be more harmful to them. We want them to use positive coping mechanisms, whether it's distraction or music therapy or massage, right? Sometimes just even dimming the lights and providing a calm environment. And we have Jean Watson. And so Jean Watson, hers was the theory of human care. And so she believed that health is harmony between the body, the mind, and the spirit. It also involves self-perception and how the self is experienced. So basically, illness is a lack of harmony within the self and the soul. And so the nursing role is a caring process to help that client regain harmony and health. And so through the caring in Gene Watson's theory, right, we're going to increase the client's self-knowledge as well as self-healing. And so, of course, that right empowers our clients or enables our clients to help them solve problems, to help them grow. And of course, the nurse also, will learn through this process, right? So as you're working with clients, we're teaching our clients things, right? We're teaching them about diseases, about medications, about coping mechanisms, about, lifestyle changes and lifestyle choices, right? Every client has the opportunity to also, educate the nurse, right? We learn things through our clients, whether it's about their culture, whether it's about their thought processes and how they deal with situations, right? So that's that mutual relationship between the nurse and the client. And so those are the major nursing theorists that we'll cover here in this chapter. So really, like I said, you get a nice little a foundation of nursing theory. The further that you go in your education, the more theory that you're going to get. And you can really learn how to apply the theories to caring for your clients. And it's just interesting if who wants to go back and get their RN when they're done? Few of you do. Um, these, like I said, you'll learn more about theories. And as you learn about the theories, right, you can really understand how they can apply to your clients, right? For example, like when I was talking about or self-care deficit, regardless of the reason why the person is coming to seek healthcare, right? There is some sort of a healthcare deficit, right? They're missing something. They need information, they need treatments, right? They need to have assistance in taking care of themselves, right? So we're meeting those demands, right? We're educating, we're providing treatments. So lots of different ways that you can see how these will be incorporated into your nursing care. Which brings us into nursing research. So uh, research, and doesn't matter whether it's nursing, whether it's in medicine, whatever, right? Um, it supports existing knowledge. It helps to develop new knowledge, right, based on observation and experimentation. So again, you can pull that all the way back to, right? Nightingale, right, when she, was taking care of her soldiers during the Crimean War, right? Again, I'm going to always go back to the hand washing, right? Why do we wash our hands in between our clients? Um, so, things like that. it's always going to have and it's um there is always going to be research that is going to be needed. Um, so some of the other things that research does, identify specific nursing interventions that are proven effective and not merely based on tradition, right? So why do we turn and reposition our clients every 2 hours, right? Why do we have them cough and deep breathe after surgery, right? What are some of the things that, why we do the things that we do? Um, so And then it also helps to provide evidence to support quality and cost effectiveness of what nurses do, right? So we know that nurses, um, you know, spend a lot of time, we spend more time with our clients, right, than any of the other providers do. Could you imagine not having nurses, right? If doctors were just the ones that popped in on you every few minutes, right? Or could you imagine doctors popping in on you every 5 minutes? We know that that wouldn't help. That wouldn't work, right? Um, and then generate knowledge for clinical practice, nursing education, and delivery of nursing services. So people like your nursing theorists and other PhD and other nursing researchers, right? They're the ones that look and, provide the rationales to support why we do what we do. All right, so there's different types of research studies. The two main types of the two main types of research studies that we do in nursing are either quantitative or qualitative. All right, so quantitative research studies are objective studies. So we use a variable to measure. Okay, so the variable is the event that the researcher is trying to measure. And we have two types of variable. We have two types of variables. One variable is the group receiving the intervention, and the other variable is the group that does not receive the intervention. All right, so if we were to say, let's say, I'm trying to think. Um, we have a group of people, we're going to split them up into two groups, okay? And let's say we're testing a new blood pressure medication. All right. So one group is going to get the new blood pressure medication, and the other part of the group is not going, they're going to get like a placebo. Okay. So we have the two different variables, right? One group is receiving the intervention, the other one is not. And then what do? We're going to collect the data. Um, what kind of data are we going to collect about medications, right? Adverse effects, side effects, the therapeutic effects of the medication, right? And then we're also going to look at the other group that's not receiving the actual medication, but the placebo. We're going to collect that same information, all right? And we're going to compare the information. And randomized control trial is the recommended type of quantitative research. Um, and so again, it really just kind of depends on how we're doing it, but we're going to compare each one. And there's a bunch of different ways that this can be done. But again, quantitative, we're collecting data, all right? And so it's more objective. With your qualitative, it's a subjective. Um, and we do use these in nursing as well. But the data is collected by interviews, and even direct observations. Okay. So, it can be, listening to people's experiences, um, and whether it's about chronic pain, it could even be specific disease processes, whatever it is, right? We're collecting information. So we're doing interviews, asking about their experiences, but it's very subjective, right? Because it's their experience. It's not objective. It's not really quantifiable, right? Um, Phenomenology is a type of qualitative study. Um, it's an occurrence or circumstance, basically, that person studies. So a case study examining the lived experiences of high school students who are both gifted and diagnosed with ADHD, right? That would be an example of a qualitative study, right? What are their experiences? Um, I'm trying to think. A grounded theory, I think, would fall under a qualitative research study as well. But again, difference between quantitative and qualitative. Quantitative is objective. We're getting data. We have data that we can show, that we can prove, right? Gives us, even statistical information, right? It's kind of like, when we collect your vital signs, right? We have numbers to back it up. Whereas your qualitative is subjective, right? It's the person's experiences, usually that we gather through interviews. So before we go into evidence-based practice, let's go ahead and take a break. Be back at 9:51. All right, so we talked about the two different types of research studies. So let's talk about evidence-based practice. So you've heard of evidence-based practice before. What is evidence-based practice? Oh, I know it's Monday morning, but what's
It's
evidence-based practice?
information, it's like based on like current decisions that they make like every 5 years. I guess like collecting information, having research to do the research to do the the nursing decision using
Mhm.
clinical um
Right.
I'm there, but I'm
You are. You are absolutely there, right?
clinical decisions.
Right. It's why we do the things that we do, right? So, why is a Foley catheter insertion a sterile procedure versus, a non-sterile procedure, right? Um, it's the research, right, behind what we do and why we do what we do. Um, so Dr. Archie Cochrane was a British epidemiologist, and he challenged the public to pay only for medical care that was proven to be effective, right? So he advocated for the use of randomized control trials as a means of reliably informing healthcare practice, right? So you've heard, I'm sure people have heard on the radio or TV or, even on the news sometimes, right? Um, about research studies that are ongoing, right? Whether it's for a disease process or a new medication, right? So we do the studies, right? The quantitative studies to test the effectiveness of new treatments and things like that. Um, and so, and he established his collaboration, which is a nonprofit organization to establish, or he established it to prepare and promote his reviews, which is a collection of evidence-based healthcare interventions that were based off of systematic reviews of research. So what does that mean? So people do research, right? And we test whatever, whether it's a new intervention, a new medical treatment, um, a new surgical procedure, whatever it is, right? So we're going to take all of this information, right? And we're going to review the research, and that is how we determine our evidence-based practice, okay? Um, so sometimes it's, a challenging the status quo, right? Why we, and I don't know if anybody's like heard this before, like why do, some people say, well, why do we do it this way, right? Because this is the way it's always been done, right? And we can challenge that, right? We can look at the research to see if there's a better way to, do something different, better, easier, whatever. Um, all right. So I don't know if anybody has heard of this. So back in 1999, um, there was a landmark research study done by the Institute of Medicine, um, and it discussed the incidence of medical errors in healthcare as well as the need for reform. So it revealed that not was it like up to 98,000 people per year died annually as a result of medical errors. And it wasn't just medication errors, right? It was things like wrong site surgeries, um, the major or what's the word I'm looking for? The underlying factor for the most part with the errors is systematic errors. It was system failures, not necessarily individuals that caused the issues. And so basically it was good people working in bad systems. They make mistakes, right? And so the focus was on fixing the systems, right? Not really the individuals. Um, and so within that report, it identified a bunch of different areas, things that could be fixed, to try to um, improve, I guess, and prevent some of these deaths that were occurring. There was a follow-up study that was done 20 years later, um, and unfortunately did not prove, even with the interventions, that there was a significant change in the amount or the incidence of medical errors that were occurring, which is kind of scary, right? Um, we have put a lot of implementations into place, or interventions, I guess, into place to try to prevent medical errors, things like, the surgery timeout. So like when you go in for surgery, there's like a timeout period, where they identify the patient, they identify the providers, right? The surgery that they're supposed to be performing and the area that they're supposed to be performing, as a way to try to prevent. It's one of the reasons why we do our 3 checks, right? For our medications administrations, or, the 2 patient identifiers, right? All of those things. And then in 2001, the Institute of Medicine also issued Crossing the Quality Chasm, a new health system for the 21st century. 21st century, can't even say it. Calling for consistent, high quality care for all people. And so, again, part of this was patients should receive care based on the best available scientific knowledge, right? So again, it's all about evidence-based practice, right? What's going to be the best for the clients, right? To show the proven outcomes. During the last 2 decades, insurance companies began to pay for healthcare practices only if their effectiveness is supported by scientific evidence, right? So FDA approval is part of this, right? There has to, it can't be experimental in a lot of cases, right? Insurance isn't going to cover again unless they're, it is supported by scientific evidence. Clients and families also are seeking the latest evidence on websites about the most effective treatment for illnesses and diseases, right? So the World Wide Web, right, is a great resource. It can be a really great resource. You can basically find anything you're looking for, right, on the internet. More and more people are doing their own research, right, and identifying what the best options are for their care. So this often, can be difficult sometimes working with some of these patients, not in the sense that, we're not providing the best care, right? But they may, want specific things, whether they're available or not. But it's definitely, right? You can Google your symptoms, right? You can go on Google and try to just basically find anything out that you want to. Um, and so even there's lots of other projects out there like NCSBN, also looks at different things when we're looking at nursing programs. There's lots of other organizations, like you have your Robert Woods Foundation, and other foundations out there that are always promoting, right, research, to try to identify the best, treatment options for people. But you can go to, like I said, you can go to NCSBN, you can go to the NLN, the Institute of Medicine, Joint Commission is another good one. Robert J. Woods. What's the other one? Joanna Briggs Institute. So if you always anybody is ever looking for um, current research to see what is out there, then those are some really good sites to go to just to see what's out there and what's available. So the elements of evidence-based practice, or how the evidence for practice guidelines is determined. There's trifecta here. We have the best research evidence, the nurse's clinical expertise, as well as the client's preferences. All right, so we want to take all of those into consideration when we are looking at evidence-based practice, right? So we want to take the research. We want to make sure that what we're doing is appropriate, right? It's the most current option. You're going to use your clinical expertise as well. And we are going to incorporate the client preferences, right? Because that is a big part of, our nursing process and how we provide care. Um, so, when we look at evidence, well, we'll look more at evidence-based practice, right? I know I heard this in my nursing career. This is how I was taught how to do it. This is why we do it this way. We've done it this way for the last, 50 years, whatever it is. It's not always sufficient anymore, in healthcare environments. Those basic things like, your sterile procedures, your washing your hands, those will never go away. Um, but even look, I love wounds. Anybody like wounds? I love wounds. Wounds are awesome. Oh my gosh. I hate the fact that people get them. That part, that's the bad part. But if you have a wound, like I am all for it. Like let's see what we can do. And so I've been a nurse for a really long time. And even if we look at, over the time that I've been a nurse, um, the changes, right, in how we treat the wounds and what we do for our clients, right, when they have wounds, a lot of that has changed, right? And it's based on what? It's based on research and it's based on clinical practice, right? You know, we develop new wound care, products and things, right? And that's, I'm just going to use that as the example, right? So it changes, it improves over time, right? So the things that we used, 100 years ago aren't going to necessarily be as effective now. Although I will say, has anybody heard of leeching? So leeching, right? That was a practice that they used long time ago, right? And it's still a practice that sometimes we'll use now, right? To help increase blood flow to areas. Um, so, think of that. I was reading another thing about the use of maggots. Has anybody heard about that? I saw that, Rachel. Your face was like, oh, yeah, because what do maggots do? It sounds horrible, but what do they do?
Ate the dead flesh.
Right, they eat the dead tissue, right? So, like, I don't know if anybody has like heard those stories about like, and then sadly, it's a big in our homeless population, right? Um, they'll have maggots in their wounds and things, right? But yeah, we're like, oh my gosh, that's horrible, right? But the maggots actually eat the dead tissue and, allow for, right, viable tissue to grow. So there are some practices, obviously, right, that have been used a long time ago and that are, maybe have not been used for a while, but then are coming back into use. So they have seen the benefit of some of these things, right? And they're also very non-invasive, right? You have to, I think to me, you would have to get away from like the psychological aspect of it. Like leeches, I'm not a big fan of leeches and worms and things like that. That might be part of it. But they do help to increase blood flow. So when we look at the nurse's role, and so the NLN or the National League of Nursing, they're the ones that establish the competencies of nursing graduates at all levels, right? And so nurses with research doctorate, okay, so that's like your PhDs. They design and implement research studies and publish their findings. Your nurses with practice doctorates, which would be like your DNPs or your Doctor of Nursing Practice, they review present research and formulate evidence-based protocols, right? So they may look at, the research that the nurses with a research doctorate performed or, other people, and they're going to do review of the literature and then right? They're going to formulate those evidence-based protocols. Nurses at the master's level can formulate research questions and evaluate the effect of evidence-based solutions on nursing problems, right? So as part of for my master's project, right? We identified an area that needed improvement on and implemented that where I was working, um, right, to try to assist. So my master's project, the provider that I was working with at the time, during my master's program, he was a general pediatric provider. His specialties were ADHD and asthma. And so asthma education is huge, especially in the pediatric population, not just, teaching kids about asthma, but teaching their parents about the disease process, right? Lots of information, lots of equipment that needs to be taught, right? How to use an inhaler, a nebulizer, your spacers, your peak flow meters, right? All of that. So my master's project, I developed um, I don't know I don't remember what I even called it. But it was basically asthma education, both designed for kids as well as adults. So, even little activities in there like, labeling the parts of your nebulizer and your inhaler and directions for use and some pictures and things. So interactive for the child. And then in the back was, more written directions for the adults um, as well as, even how to understand reading their asthma action plan. So, with nurses with bachelor's degrees, right, they can identify questions needed to be studied. They can critique published research. They can also use evidence, right, as solutions to nursing problems. Your associate degree or diploma nurses challenge the status quo, questions assumptions, offer new insights to improve the quality of care. And then your practical nurses, again, question the basis for nursing actions by considering research, evidence, tradition, and client preference. So, what does that mean? So, as a future practical nurse, right, you can participate in research. You can look at current articles. While you're in school or even when you get out into practice. Um, and one of the nice thing about being newer nurses, right, is you guys have fresh eyes and fresh thoughts and ideas coming into nursing practice, right? And so you can look at how we do certain things, or even when you get into your current, your place of employment after graduation you can, as you're learning policies and procedures, and even using your nursing skills, You can question things like, why do we do it this way? It would be easier to do it this way. Do your research, present your research. Um, as like I said, as new nurses going in with fresh eyes, coming right out of school, you may be able to identify things that people, we just do things because that's the way we do them sometimes, right? And so challenging the status quo is not ever a bad thing, right? It can help to make things better. And hiring managers will tell you, as even as new nurses, if you want to, question how things are being done. Um, Most hospitals have libraries, and librarians on staff too, so that if you want to do research to find a better way to do something, do it and present it to your management team. It's a good way to kind of get yourself known as well. Just make sure, like I said, that you do your research and you present it. But they want people to do that, to help to try to make things better. And that's your spirit of inquiry. Okay. So the spirit of inquiry is raising questions. It's challenging, right? That status quo, and the existing practices, even seeking creative ways to solve problems, and I will go to long-term care for this all day long, right? When you look at working in long-term care, right? And you guys have done clinicals in long-term care, right? So you've seen the difference between long-term care and a hospital system, right? In a hospital, you have lots more resources, right, available to you. You've got bed alarms, you've got side rails, right? You have much smaller nurse to patient ratios, right, within a hospital system. And then you go into a long-term care, and what don't have? Bed alarms, right? You don't have side rails. You don't have the smaller nurse to patient ratios, right? So lots of different just many differences between you don't have all the resources in long-term care. So fall prevention. Fall prevention in long-term care is huge, right? Because we don't have a lot of the things in place like the hospitals do to try to help prevent them. So, right, we have to get a little bit more creative. And that's where your research would come into play. What are some of those out of the box type things that we can use to try to help prevent falls, right, in those nursing homes? Um, which, trust me, we know that falls, whether it's in a nursing home or even in a long-term care setting, right, can be devastating, and lead to some serious consequences for our clients, whether, they get hurt or not, right? Because you fall once, then you have the fear of falling again, right? And that can be very scary for our elderly clients, or even not even our elderly clients, even some of our, younger clients, depending on what you know, their disease or their mobility issues are. So again, just as a recap, so today we talked about nursing theory. So why we have nursing theory is we talked about Nightingale and Maslow and Orem and Leninger. Um, you know what? I just realized something. We missed a theorist. So we missed Hildegard Peplau. So Hildegard Peplau, her theory was the interpersonal relations theory. And so it's a basis for how we develop our therapeutic relationship with our clients, right? You've heard about building therapeutic relationships and therapeutic communication. Um, and so her theory says that the relationship that's developed between the nurse and the client has certain parameters and is the major part of the treatment. And so there's four overlapping phases that occur. when we're building that therapeutic relationship. And so the first phase is the orientation. Okay, the client seeks assistance because they have a felt need, right? That's usually how we come in contact with our clients, right? Whether they're sick, they're injured, they've had a trauma, and they have, sought assistance. Um, so the problem's been identified, and then the nurse is going to work with the client to help them recognize the problem. And then during the identification phase, the client understands the situation and they will respond to the nurse that is providing the care. During the exploitation phase, the client begins to depend on the nurse and uses the help offered, right? So they resign to accept the help that is or the care that is needed. And then during the resolution phase, right, now the relationship is becoming to an end. The dependent behavior of the client, right, needs to be given up, right? They need to become more independent, um, and start to care for themselves, right? And that's usually when the clients are discharged, right? They go home. Um, but as nurses, right, especially during this relationship, right, we're educators, we're, advocates for our clients, counselors, right? We're providing a bunch of different roles within that therapeutic relationship. And then we talked about Sister Callista Roy and Jean Watson. We talked about nursing research, the difference between the qualitative and the quantitative research studies. Talked about how evidence-based practice comes to play, and the elements of evidence-based practice and the nurse's role. Anybody like to do research? Yeah. I don't mind doing research. Like I will, research articles all day long. I don't like to write. That's probably the biggest thing. Like I can read research articles all day long. I just hate to have to write and put it all together. That's usually the hardest part for me. But it is interesting when you go and you read through research articles and learn how to critique them. And, because there's a lot of information that you get within those research articles, and it can be a little confusing and overwhelming at times to try to figure out what is the actual meaning behind what they're trying to say. So, all right. Does anybody have any questions about any of the information that we went over today so far? No. All right. So let's see. We are going to do some practice questions. I'm just trying to debate which ones I want to do. And for some reason, my computer is giving me a hard time. So give me 1 second. All right. Let's see. We're going to do assignment delegation and prioritization. So we'll start, let's see. All right. So I am going to share my screen. So what we'll do is you can put the answers in the chat or you can call them out either way. So I started with 20 questions. Again, we're going to do, what did I say? We're going to do assignment, prioritization, and delegation. So it's going to have combination. It means obviously there's going to be med surge in there. So you can either call out the answer or you can put it in the chat, whichever is easiest for you. All right, I will share my screen. All right. All right, so first question, we have a newly hired nurse experienced harsh criticism from the preceptor during orientation. Upon completing orientation, the charge nurse assigned her the most difficult and complex patients. What would the new nurse do first? So we have would use assertive communication to discuss the assignments with the charge nurse, or talk to the nurse manager about the behavior of the charge nurse and preceptor, or make a formal written complaint and submit it to the Human Resources Department, or review the facility's policies on horizontal violence, such as bullying and harassment. So we have a newly hired nurse experienced harsh criticism from the preceptor during orientation and has been assigned the most difficult and complex patients. What should we do first? So we got 1, 2, and 4 are the options so far.
I was thinking one.
Review
1,
the
3. We got all the answers now. All right, so let's go with 1. 1, assertive communication, right? So the first action would be to talk directly to the charge nurse about the assignments, right? Which we know as a new nurse, that could be very difficult. But remember, assertive communication, right? It can be carefully planned and then delivered with a calm and non-confrontive tone of voice. The other options may also be considered if the nurse continues to experience harassment or bullying from other members of the healthcare team. Give me one second. Excuse me. All right, good job. All right, number 2. Which assistive personnel needs a reminder on providing denture care? So APA places a towel in the sink, then fills the sink with 1 inch of tepid water. The next one puts on gloves and grasps the front teeth to remove the upper denture. The third one brushes all denture surfaces with a brush using a commercial paste. And then the last one rinses the dentures with hot water and stores them in a clean, dry cup. So which one of those assisted personnel needs a reminder on providing denture care?
rinsing them with hot water.
So rinsing them with hot water. So that is 4.
I agree with that one too.
All right. Anybody else? We'll go with 4. All right. So yes, hot water can warp or damage or warp or can't even say it, warp or soften dentures, right? So we should use tepid water for cleaning and rinsing. And then yes, they are stored in a clean labeled cup with cold water, right? We don't want to put them in just, dry hanging out there. Good job. All right. Um, which, oh gosh, which specimen collection method is the most important to modify if a patient has a low platelet count? All right. So which specimen collection method is most important to modify if a patient has a low platelet count? So one, blood serum sample for blood typing, two, stool sample for ova and parasites, three, a midstream urine sample for urinalysis, or expectorated sputum sample for culture. Jeez, it's like
I
a tongue
say
twister for
one.
me.
I would say one. The blood
One.
I
serum
was thinking
sample.
one.
Okay. So what would it mean if I had a low platelet count? Sorry, my nose is like, I've been 2 weeks I've been dealing with this. I apologize.
Low platelet count, you'd be getting sick.
Platelets, platelets.
And the platelets have
Would
something
that,
to do with your blood.
I
Yes.
guess it wouldn't be able to have like blood clots
There
or
you go. Right. If I
cover.
have a low platelet count, right, my blood's not going to clot. So when we say blood serum sample for blood typing, absolutely correct, right? Why? Because if I access their vein, go to draw some blood, right, what could potentially happen, right? They can continue to bleed. Um, so that low platelet count can cause excessive bleeding, right? So to prevent untoward bleeding, the collection method would include using a small gauge needle, holding firm pressure on the puncture site for at least 5 minutes, and thereafter rechecking for continued bleeding or oozing. Um, so I'm going to use an example. So I had a surgery, and they had given me some heparin during my surgery. And so when I was getting ready to leave, of course, when they pulled my IV out and she just put like a little band-aid over it, and I'm getting dressed and I literally noticed there was blood all over my shirt. And I was like, where did the blood come from? And here where they had pulled my IV site out after giving me the heparin literally was oozing everywhere. And I had to go home with blood everywhere, looking I had just like been in a trauma. So really important to keep an eye on that site. And that's, for low platelet count, but it's also for people that are on blood thinners, like your heparin, your warfarins, even like your Lovenox and things like that. All right. Before the end of the shift, the nurse is rounding on assigned patients and performing a quick head-to-toe assessment. Which patient has the priority finding? All right. So we have a patient with kidney stones that has a score of 7 out of 10 on the pain scale. An opioid naive patient has slow, shallow respirations. We have a post-surgical patient with pale, clammy skin, or an elderly patient is more confused compared to baseline. So which one of those has the priority finding?
It would be two because of the ABCs, they're breathing. I think that's
Yeah,
what you want
that's
to
what
look
I
at
was
first.
thinking as well.
Same
I would.
here.
Oh, all right. Absolutely, right? ABCs. So shallow respirations could be having respiratory depression, right, related to the opioids. So we're going to assess responsiveness, check their pulse ox, reposition, and potentially get that prescription for naloxone. Other patients also require additional assessment, but yes, this shows slow, shallow respirations are your priority. All right, we have a select all that apply. So, which guidelines are included as good body mechanics for lifting and moving? So, bend forward from the waist to pick up objects, use thigh, arm, or leg muscles rather than the back muscles, elevate the bed to work at a height that minimizes bending, keep the trunk straight, do not twist when lifting. Use a wide base of support, feet apart at shoulder width, or push objects away rather than pulling them forward. So which one of those would be good body mechanics?
3, 5.
So we got 3, 5. Oh,
I think 2 and 3 will be involved
Yeah,
in
I was
that.
about to say 2.
2.
Maybe 4.
4, because you don't want to twist when lifting,
Okay.
because you could throw your back out.
All right. So we got 2, 3,
I
4, and
think that's
5.
it.
Anything else?
I'm thinking about 6, but I don't know. That's in the air for that one.
What is easier to do on your body, pull or push?
Yeah,
Push.
6.
So 6? Yeah. Okay. Oh no. Nope. I threw that out there. I'm sorry. Just wanted to keep y'all guessing. So yes, decrease strain. So obviously we know, and remember good body mechanics. Just because you know them, you have to incorporate them into your practice, right? Um, what's the number one injury in nursing?
Back strain.
Back strain, right? So using your other muscles. Always elevate that bed, bring it up to a working position. There is nothing worse than trying to bend over to try to do something. Um, keep your trunk straight, use your wide base of support. All right. Which incident would involve the State Board of Nursing in fulfilling its primary purpose? Ooh, here's a good one. All right. Number 1, an older experienced nurse receives less pay than a recently hired new graduate nurse. Number 2, nurse experiences sexual harassment from a supervisor and healthcare providers. Number 3, nurse is practicing with an expired license and fails to assess a patient's cast forearm. Or number 4, several nurses are fired by hospital administration for trying to start a nurses union. Gosh. So which one of those, would require or would involve the State Board of Nursing?
3.
3.
Anybody else? I only got a couple here. All right. So number 3. Absolutely correct, right? So the primary purpose of the State Board of Nursing is to protect the public and promote safe practice by ensuring that nurses are licensed, competent, and acting within within their scope of practice. Oh my gosh. Did you guys hear I hate to say it like that, but there's been a lot of fake nurses lately. There's been a lot of fake nurses lately. Um, so, you know, who's res so when we look at their responsibility, right? One thing that all employers should do appropriately is verify the nursing license, right? When somebody gets hired, just take their word for it that they have a nursing license. Um, And my husband was telling me a story, and I don't know what state it was in, but she got hired, I guess, right out of school, and was working as a nurse. Um, and for a few years, she had failed her NCLEX, but was still working. And I forget how she got caught. I don't remember what my husband said or how she got caught. But literally, like the day that she got caught, she had literally like just passed her NCLEX. I was like, oh my gosh, yeah. Um, but I mean, again, the State Board of Nursing, right, is to protect the public, but all employers too. So like I wonder where the what's the word I'm looking for? Like where the disconnect was, why nobody bothered to like verify her license, and then just kept, letting her work. Um, because you get your what is it your authorization to test after you graduate, right? You have, I want to say, well, it used to be 90 days, but I think some state board of nursing have actually like toned it down to like 45 or 60 days now, that you can work as like a graduate practical nurse while you were waiting to take your NCLEX. Um, And then, once you pass your NCLEX, obviously you can continue to work. But during that time, if you fail your NCLEX, you have to stop working. You can't work as a graduate practical nurse anymore, even if it's within that time frame. But it's, not only is it the nurse's responsibility to inform their employer, like, hey, I passed my NCLEX, or hey, I didn't pass my NCLEX, right? It's also the employer's responsibility to verify those licenses once they do hire somebody. All right. Which documentation entry needs to be flagged so that the general guidelines for documentation can be reviewed with the nurse who made the entry? So, which documentation entry needs to be flagged so that the general guidelines for documentation can be reviewed with the nurse who made the entry? So, we're looking for the incorrect documentation. So, number one, 1330, Dr. Smith reviewed and explained surgical procedure, consent form, consent form signed and witnessed. Number two, at 1400, registered nurse assesses pain at a 7 out of 10 on the pain scale and administers morphine as needed. Number three, at 1545, sacral wound irrigated with 100 mLs of sterile normal saline, pain tissue and small amount of serous drainage noted. Oy. Or number four, at 1730, liquid nutritional supplement refused. I don't like the taste. Offered, or other flavors offered but declined. So which one of those would need to be changed?
Number 4.
Or
Number four. Anybody else?
I think number 2.
Number two. Anybody else? I got 1, 2, and 1, 4. I need a tiebreaker.
Two.
2. All right, let's see. Correct. So documentation should be done by the health team member who performs the action, right? So that LPN did not assess their pain or administer the morphine, right? The RN did. So the RN should have been the one to put the pain assessment in, as well as document, right, the fact that they gave the pain medication. Good job. All right. Which nurse is most likely to be held liable for nursing malpractice? So nurse A assigns too many patients to the assisted personnel. Some do not get a shower. Nurse B fails to report worsening condition, and the patient sustains permanent damage. Nurse C leaves before shift report. No patient is harmed, but oncoming nurses are upset. Or 4, Nurse D is demeaning and uses condescending language, and the patient gets angry. So which one could be held liable for nursing malpractice?
2.
Yeah, 2.
2. All right. Very good. Yes. All of the nurses have failed to give high quality nursing care. However, a malpractice claim includes 4 elements: your duty, your breach of duty, causation, and damage. So Nurse B had a duty to the patient, failed to fulfill that duty, and this breach resulted in permanent damage. Good job. All right. The nurse is supervising the nursing student who is performing a procedure. Which action by the nursing student requires correction? So 1, checks agency policy and procedure manual before beginning the procedure. 2, checks the order, collects equipment, and performs hand hygiene. 3, provides privacy, raises the bed to working height, and ensures the wheels are locked. Or 4, identifies self, starts procedure, and explains each step as it is performed. So which of those actions would require correction?
Four.
4.
4, because she ain't wash her hands.
4.
4. All right. Yes. Student has skipped the critical element of identifying the patient using 2 identifiers before beginning the procedure, and then the other actions are correct. So good job. All right. Which patient would benefit the most from a therapeutic oatmeal bath? So 1 has itching and irritation secondary to dermatitis, has an open wound in the lower extremity, or has a fever and needs cooling measures, or has discomfort secondary to rectal surgery.
1.
No.
1.
1.
Yes. Oatmeal or starch baths are soothing for irritated skin. Also, skin is patted dry rather than rubbed. This decreases itching and scratching. Good job. All right. The nurse is using the PQRST mnemonic device for pain assessment. Which question would the nurse ask to assess the S portion of the mnemonic? Oh, I didn't finish reading. Sorry. 1 is the pain in a single location, or does it radiate to other parts of your body? 2, on a scale of 1 to 10, 1 as the least and 10 is the worst. Which number best describes your pain? 3, when did the pain start and approximately how long did each episode last? Or 4, do you have any ideas or thoughts about what could be causing the pain? So using the S portion of the PQRST pain assessment, what question would we ask?
I guess it would be 2 since S is like severe. So that's how they
Yeah,
would describe their
2.
pain throughout the 10.
I'll say
That's
2.
30.
Okay, so 2. So yes, in the PQRST mnemonic, P is precipitating events, right? Which is the cause of the pain, what makes it better, right? What makes it worse? Q is the quality of pain, throbbing, burning, dull, aching, stabbing. R is for radiation, S is for severity, and then T is for timing. So good job. Yep. On a scale of 1 to 10, what is your pain? All right. The nurse needs data to determine if the patient has a pulse deficit. Which task would be best to delegate to the assisted personnel? So, one, begin counting the radial pulse for a full minute when signaled. Two, take a radial pulse, then listen to the apical pulse for a full minute. Three, check and report pulse deficit when taking routine vital signs. Or four, check the radial pulse for a full minute on each wrist. How do we assess for a pulse deficit?
So it'd be
Don't you
one,
take the radio pulse and listen to the apical pulse for a full minute?
you have to do it at
Yep,
the
so
same time.
what can we, I'm sorry, somebody else was talking. Go ahead. No, I meant like somebody else was saying something like, what were you saying?
I was saying you have to do it at the same time, so
Right.
it would be one.
Good job. Right. Yeah. So when we're assessing for a pulse deficit, right? It does. It has to be done at the same time. So,
So
right.
that's where
So,
you do it like systematically. You the comparison.
so for a pulse deficit, you're comparing apical versus radial. So the nurse would be listening to the apical pulse while your AP is checking radial pulse, and then you'll compare the numbers when you're done, right? So the pulse deficit is noted when there's a discrepancy between the apical and the radial pulse. Two members of the healthcare team must work together, right? Upon signal, one counts the apical pulse and the other counts the radial pulse for a full minute. Then the radial pulse is subtracted from the apical pulse, and that would give us a pulse deficit if the client had a pulse deficit. All right. In which situation has the nurse made the greatest error in delegation and instruction to the AP regarding the movement or transfer of a patient? So one, we tells the AP to put the ambulatory patient in a wheelchair and push him to the dining room. Two, ask the AP to use a draw sheet and pull the patient from the bed to a pull the patient from a bed to a stretcher. Three, tells the AP to log roll and reposition a patient with a recent spinal cord injury. Or four, ask the AP to remind a quadriplegic patient to do range of motion exercises. So which of those would be the greatest error in delegation?
It'd be four.
So I got a 4. 1, 4,
I was thinking maybe 3.
and a 3. I got a 3 and a 4. Does anybody have a tiebreaker?
I was thinking 3 as well because of the spinal cord injury.
Okay. All right. So yes. So all of these instructions could use improvement. However, the assisted personnel should not independently log roll or reposition a patient with a recent spinal cord injury. Improper technique could cause damage to the spinal cord and permanent paralysis. Has anybody ever did you guys do, you should have done log rolling in your skills lab, right? Or no? Maybe. Has anybody ever log
In
rolled a
STNA
patient?
class.
No, nobody has ever practiced log rolling. So any of your spinal cord patients, if they need log rolling, then it's definitely not a one-person job. All right. During bed making, the which nursing student requires a reminder from the supervising nurse? So one, student A raises the bed to working height and uses a wide base of support. Two, student B changes linens on one side of the bed before moving to the other side. Student C carries soiled linens away from the body and puts them in a linen hamper. And four, student D takes unused and unsoiled linens back to the central linen cart. So which of those require a reminder from the supervising nurse?
Maybe one.
Okay, we got a one.
Um, 4, student D.
Okay, we got a one and a four.
I'll go with 4 as well.
Four. All right. I had the tiebreaker. So student D needs a reminder. So remember, anything we bring into a patient's room is now dirty. It's contaminated, whether you use it or not. If you bring it into a client's room, it is now dirty. So it would, even if you didn't use it, then it would still be considered dirty. You would have to send it to laundry. You couldn't put it back in the clean linen, because you never know, right? Something in that room can jump on that linen, right? And now you you end up contaminating everybody. All right. 4 patients need vital signs assessment and care after undergoing various diagnostic procedures. Which patient can be safely assigned to the AP for assistance and taking vital signs? So patient had a thoracentesis that was performed at bedside. Patient had a pelvic exam and a pap smear. Patient had a lumbar puncture performed 1 hour ago, or patient returns from the x-ray department after having an arteriogram. So they need vital signs assessment and care after their diagnostic procedure. Which one can we safely assign to the AP for assistance in taking vital signs?
2.
Two. All right. So correct, right? So you have to know what your possible post-procedure complications are, right? And so pelvic exam and pap smear are non-invasive. So generally speaking, that's pretty safe. All right. Which of the displayed heart rhythms would the nurse identify as tachycardia? So here we go. Can y'all see that? I don't know if I can move it or make it bigger for some reason. There we go. All right. So which one of these is tachycardia? A, B, C, or D?
Looks like B.
Looks like B. Never seen PQRSTs like that before. No, I'm just kidding. So B, all right. Yes. So B, tachycardia is a rapid or fast heartbeat. In a normal rhythm, the heartbeat is regular and pauses between beats are even. So yes, good job. All right. The nurse instructs the AP to collect stool specimens from several patients. Which patient's specimen must be immediately taken to the lab after the AP collects it? So, one, the patient has diarrhea and stool culture is needed to rule out Clostridium difficile infection. Two, the patient reports dark colored stool for several days with subjective feelings of fatigue. Three, the patient has diarrhea and mucus stools after drinking water from a mountain stream. Or four, patient reports pain and small amounts of bright red blood during defecation. So which one of those needs to be sent immediately to the lab after the sample is taken?
Four.
Four.
I'm stuck between 4 and 2.
I was
Yeah.
gonna say
Yeah, same
three.
here.
Eeny, meeny, miny, mo. We'll just do, let's do, I don't know. All right, we'll do four, see what happens. Or three is correct. Wait, what? Oh, three is correct. So, patient has diarrhea and mucus stools after drinking from a mountain stream. So, granted, it says ideally all specimens are transported to the lab as soon as possible. However, the onset of diarrhea and change in stools after drinking contaminated water indicate testing for ova and parasites, and the specimen must be fresh within 2 hours. Interesting. Okay. Look, we all learned something new today. All right. Which instruction would the nurse give to the assistive personnel regarding the use of a temporal artery thermometer? So, one, if the patient has been eating or drinking, wait for 15 to 30 minutes before taking the temperature. Two, switch the thermometer to the temporal artery setting and use the red probe. Three, slide probe across forehead, keep button depressed, lift probe and touch on the neck just behind the earlobe. Or four, place the patients in the Sims position and wipe the skin to remove perspiration. So how do we use a temporal artery thermometer? No, I'm like reading it too, so
Nobody heard me or what?
I'm sorry.
Number three?
Number three.
Yeah.
All right. Anybody else? Nobody. Everybody's looking at it like, we're an answering this one. All right, so we had number three. So number three is correct. So temporal artery thermometer is considered the most accurate way to measure temperature. Probe is usually slid across the forehead above the brow. If perspiration is present, the temperature can be measured by touching the neck just behind the earlobe. So good job. All right. A 74-year-old patient with COPD displays difficulty breathing and increased coughing, productive of yellow-green sputum. Vital signs are temp 30 or 100, temperature is 100 degrees Fahrenheit, pulse is 88 and irregular, respirations are 24, blood pressure is 140 over 88 with the O2 sats of 92% and 1 liter of oxygen. What is the priority nursing action? So, one, report the findings to the healthcare provider. Two, ask the respiratory therapist to deliver an as needed breathing treatment. Three, increase the oxygen as needed until the O2 sat is 98%. Or four, administer acetaminophen 650 milligrams by mouth for fever. So a 74-year-old patient with COPD displays difficulty breathing and increased coughing, productive of yellow-green sputum. What is going to be our priority nursing action?
One, because of
One,
the yellow green sputum.
I'm thinking one.
one. All right. Correct. So patient's fever and yellow-green sputum indicated possible respiratory infection. The healthcare provider should be noticed for assessment, diagnosis, and treatment. A respiratory treatment may be given, but is not the priority and could delay treatment of an infection. All right, good job. All right, a patient who returned from a bronchoscopy several hours ago develops difficulty breathing and chest pain and is coughing up blood. Which intervention should the nurse perform first? So, one, place the patient in a semi-Fowler's position. Two, apply electrocardiogram electrodes. Three, apply oxygen as ordered. Or four, immediately report the findings to the registered nurse. What's our priority? We got somebody that just had a bronchoscopy, is difficulty breathing, chest pain, and coughing up blood.
I'd say report to the RN because of the blood coughing.
Semi-Fowler's. So the first thing we should do is protect the airway by placing the patient in a semi-Fowler's position. And yeah, so we want to make sure they have an airway. And then, of course, we're going to notify the RN. So good job. We'll go ahead and take a break and then I'll get some more questions. So be back at 11:15.
Hey, Tasha.
Yes, I can hear you.
Okay. I was just wondering, because I feel like this is all like kind of complicated. I was wondering, like right after this, do you have a minute that we could just stay on in London too? Can you hear me?
Yeah, I emailed you back.
Oh, okay. Yeah, sorry, I was talking to Kristen too. So, like right afterwards, will that be good for you
Yeah,
guys?
that's fine.
Okay.
I can hear you, Sarah.
All right.
Mhm.
Excuse me. All right, so this time I pulled up some next gen style questions. So we'll see. These are some of those different types of questions. All right, so let me share. Maybe. There we go. There we go. Okay. Sorry, I don't know why that took so long. Okay. So the nurse uses knowledge of anatomy and physiology to locate the pulse points for assessment and intervention. So we're going to refer to the figure and select the best pulse sites for each nursing action listed. So each site may be used only once. So I'm going to scroll this down as I'm trying to, if I make it any bigger, it's going to go. So here is our figure. All right. So we'll start. Sorry, let me answer this real quick. All right. So we'll start with checking for pulse during one-man CPR. What pulse point are we going to use? A, B, C, D, E, F, or G?
B.
I thought I heard somebody, but I didn't. I don't know if I did or not.
B.
B, okay. So B, oops, where'd my picture go? All right. So taking a routine blood pressure.
D.
D, is that what you said, Matthew? Okay. All right. Oops. Oh, not sure I like. Okay. All right. Auscultating heart rate and rhythm.
C.
We already used B.
C.
C.
Yeah, I said C.
I'm sorry. I didn't hear you. Okay. Um, obtaining an arterial blood, or I'm sorry, an arterial body temperature.
A.
A. Locating dorsalis pedis pulse was unsuccessful. Let's see if I can make this picture bigger.
I.
All right, we got an H and an I. We need a tiebreaker. Okay, I. Let's see. I. All right. Let me go back, get my picture back. Checking perfusion in the distal lower extremities.
Can we switch the one before to H and then that one I?
Okay, so this one would be H and then this one would be I. Okay. Assessing femoral artery insertion site after cardiac catheterization.
F.
Okay. Obtaining pulse rate during routine vital signs.
E.
And then assessing lower extremity for peripheral artery disease, Doppler device may be needed.
I think G was the last option.
Yeah, I think that's the last one we got. All right. All right, here we go. Good job. Yes. All right. So, next one. The nurse is caring for a 25-year-old patient with chest trauma following a motor vehicle crash. A thoracostomy chest tube was inserted into the left pleural cavity 2 days ago to alleviate hemothorax. Vital signs are stable and the patient is alert and oriented. So this one, we are going to select the appropriate staff for each action. Staff may be used more than once. So I'm trying to see. All right, if I click, we have the supervising RN, we have the LPN, and we have an assistive personnel. So to temporarily clamp the tube to assess for an air leak, who would perform that?
I'm thinking RN.
RN, okay. Mark the amount of drainage in the water seal collection every 8 hours.
LPN.
Monitor and chart the amount and character of the drainage.
LPN.
LPN. All right. Instruct the patient to cough and deep breathe.
UAP.
All right. Replace the water seal drainage system as necessary. RN. I got an RN. All right. Monitor the patient for crepitus.
LPN.
LPN. Assist the patient in changing positions to enable drainage and ventilation.
AP.
Okay. Assist the patient with bathing.
AP.
And assess complaints of new onset left chest discomfort. RN. All right. All right. What did we do? All right. So we did the nurse can or the RN temporarily clamp the tube to assess for an air leak. I'm trying to see which one we didn't get right. Let's see. So clamping of the chest tube to assess for air leaks must be done by the supervising RN. The LPN should monitor, chart, and mark the amount of drainage on the drainage system and instruct the patient in coughing and deep breathing, as well as monitoring the patient for crepitus to assure accuracy. An assistive personnel can assist with position changes in bathing. The supervising RN must replace the water seal drainage system if it becomes full or cracked, and the RN should assess any new complaints of chest discomfort. All right, so the coughing and deep breathing was the one that we did incorrect. So this one needed to be the LPN. All right. the nurse is reinforcing patient teaching for a patient on how to use a peak flow meter. So select from the options provided to place the steps in the correct order for how to use a peak flow meter. All right, so the options are, so we have the patient records the value and resets the pointer, rest for a few breaths. The nurse instructs the patient to set the pointer to 0, take a deep breath while standing, make a firm seal with lips around the mouthpiece, then blow fast and hard, and then rest. Repeat the process for a total of 3 readings. All right, so what are we going to do first?
Put the pointer to 0.
Okay, we're gonna put, where to go? Where to go? Where's the, oh, here it is. Okay. All right. Then what?
Take a deep breath while standing.
All right, so this will be second. All right, then what?
Make a firm seal.
Make a firm seal. Okay.
Rest for a few breaths.
Okay.
Record the values and reset.
Yeah.
Let's do this one first and then, okay. All right, so oh wait, we did that backward. I did that backwards. That was my fault. You said this one first. Okay, that was my bad. All right. So first is the first step is make a firm seal with lips around the mouthpiece, then blow fast and hard. Second is take a deep breath while standing. Third is record the value and reset the pointer. Fourth is rest. Fifth, set the pointer to 0. And then 6, rest. Repeat the process for a total of 3. All right. All right, complete the sentences by choosing the most probable option for the omitted information from the list of options provided. So pulmonary edema is caused by right or left-sided heart failure.
It'd be left side.
Left lungs.
Nursing priority interventions for acute pulmonary edema includes placing the patient in a what position?
High Fowlers.
High Fowlers, yeah.
High Fowlers. Administering oxygen to keep the oxygen saturation between
98 to 100%.
98 to 100%. Everybody's good with that? Administration of what medication, hold on, is given for diuresis?
Furosemide.
Furosemide. And then blank is the best indicator of fluid increase.
Weight gain.
Good job. Weight gain. All right. What did we miss? All
I
right. So
think it
we
was the
got
percentage because I was looking at that and I think it's like it has to be greater than 90, but it will still start off like at 93%, I
very
believe.
good. Yes. So we do know that it is pulmonary edema is caused by left-sided heart failure. Nursing priority interventions for acute pulmonary edema include placing the patient in a high Fowlers, administer oxygen to keep the SATs between 93 and 95. And then we give Lasix or furosemide for diuresis, and weight gain is the best indicator of fluid increase. So yes, the 93 to 95%. All right. The nurse and assisted personnel are assigned to care for a patient who has been unresponsive for several weeks after a drug overdose. The patient is breathing and displays purposeful withdrawal from painful stimuli and occasional incomprehensible sounds. Which tasks could be assigned or could be delegated or assigned to the AP? So we have an unresponsive patient that's been unresponsive for several weeks, but now they are breathing and they display purposeful withdrawal from painful stimuli and occasional incomprehensible sounds. So what can we delegate to the AP?
They can record vital signs every 4 hours.
Okay.
Yeah.
Vital signs.
Thoroughly clean and dry the perineum.
Okay.
Perform mouth care every 2 hours with sponge swaps.
Okay.
Perform
Talk
passive
to the
brain
patient.
definition.
Okay.
Reposition every patient.
Reposition
Reposition patient
every
at least
2
every 2
hours.
hours.
Okay.
I think it would be talk to the patient and explain the actions that are given.
Okay. All right. Let's see. Good job. Yes, absolutely. So the AP can be assigned the vital signs, the hygiene, the range of motion, and positioning. And then the nurse is going to perform any of the assessment tasks. But I'm glad I didn't see exactly who said it, but yes, talk to the patient and explain actions as care is given. Just because they are unresponsive, right? Even if they were in a coma, right? We always talk and let our patients know what is going. Remember, the hearing is the last sense to go, so they can still hear you. All right. So the nurse is providing care for a 79-year-old patient who has dementia and is unable to perform self-care. He is incontinent and wears adult diapers. His medical history includes cataract surgery and hypotension. He is unable to feed himself and has a poor appetite and has lost 10 pounds over the past month. The AP checks his diaper every hour and changes it as needed. He is repositioned every 2 hours using a pull or draw sheet. The healthcare provider is planning to insert a feeding tube. Select to highlight the factors in this case study that increase the patient's risk for developing a pressure injury. Okay, so what factors increase their risk for developing a pressure injury?
He is repositioned every 2 hours using a pull draw sheet and not physically move.
Okay, let's see. What do I highlight?
He wears incontinent diapers.
Maybe click on it.
Oh, okay. It won't let me click on that one.
Unable to perform self-care.
Okay.
Unable to do that. We're gonna get no pressure injury or appetite. He lost 10 pounds.
Okay.
He has dementia.
Dementia.
You might be able to click repositioned.
No, it won't let me click on that one.
Hypotension.
Okay. What else would increase the risk for
What
pressure
about poor
areas?
appetite?
And
The feeding tube.
Unable to feed himself.
yep, I think that is all we can click on. All right, let's see. What did we do? So we got dementia, unable to perform, incontinent. Oh, I clicked hypotension, but it wasn't correct. So pressure, injury, risk factors, immobility, inactivity, moisture, malnutrition, advanced age, altered sensory perception, decreased mental awareness, as well as friction and shear. But it wouldn't like, I don't know. But yeah, so the only thing that we clicked that we shouldn't have was the hypotension. All right. So residents who live in a long-term care center have varying degrees of dementia. Some need reminders to perform ADLs. Some can function with step-by-step coaching. Others will require modified, partial, or total assistance to achieve tasks. The nurse works in a facility where the nurse to resident ratio is 1 to 30, whereas the ratio of AP to residents is 1 to 10. Therefore, the nurse must delegate or assign much of the bedside care and interaction to the assisted personnel. With appropriate supervision from the LPN, which tasks related to reality orientation for residents with dementia can be delegated or assigned to the assisted personnel? All right, so which of these can we assign to the assisted personnel? Lead a reality orientation group for residents and interested family members. Position a clock with large numbers in a resident's room in clear view. For residents with global amnesia, repeat orientation of person, place, and time. Provide care and mental stimulation according to the resident's wishes. Keep environmental lighting low and dim to minimize confusion. Ask one simple question at a time and allow adequate time for a response. Engage residents in conversational topics at a normal pace as care is performed. Look directly at the residents when speaking and place seasonally appropriate decorations in the day area. All right. So can we delegate to lead a reality orientation group for residents and interested family members to an AP? Can they lead a reality orientation group? No. Okay. Oops. I hit anyway. All right. Can they position a clock with large numbers in a resident's room? And okay. For residents with global amnesia, can they repeat the orientation of person, place, and time? Okay. Can they provide care and mental stimulation according to the resident's wishes? Yes. All right. Can they keep the environmental lighting low, or should they keep the environmental lighting low and dim to minimize confusion? All right, I'm just looking at head nods. So ask one simple question at a time and allow adequate time for a response. Okay. Engage residents in conversational topics at a normal pace as care is performed. Yes, no, yes, okay. Look directly at residents when speaking and place seasonally appropriate decorations in the day area. Yes. All right, so you selected all of them except for the reality group. So let's see. All right. So here, let's read the rationale. So positioning a clock, where's the clock? There it is. All right. So positioning a clock or calendar, asking one simple question at a time, looking directly at the person when speaking, and placing seasonal decorations are correct interventions that can be delegated or assigned to the AP. So we can't do, right? So leading a reality or a reality group should be done by an RN because formative evaluation occurs during the activity. Repetitive reality orientation for persons with global amnesia is not effective and may increase frustration or agitation. AP should follow the care plan that is specific for each resident. The AP would report to the nurse if the resident refused care or requests change. The environment should be well lit. Inadequate lighting is a safety issue, and decreased visual acuity contributes to confusion. Engaging residents in conversational topics at normal pace during care is generally a good strategy. However, for patients with dementia, excessive stimuli or distraction can be confusing. Thus, APs may need to be instructed to focus on the task at hand and speak slowly and give brief explanations. So we'll do the AP can position the clock, ask one question or ask one simple question at a time, look directly when speaking, and place the seasonally appropriate decorations in the day area. All right. The nurse works for a home health agency and is assigned to be part of the team that will care for a new patient. The patient is an elderly gentleman who has Alzheimer's disease. He lives at home with his wife, who is the primary caregiver. The wife reluctantly agreed to home health care after being convinced by her daughter. The patient's symptoms were progressing slowly from mild to moderate, and there has been a recent change in his medications. Which tasks are best performed by the LPN LVN? All right, so what tasks can the LPN LVN do? Monitor abilities to perform ADLs, encourage family members to express concerns, assist the patient with bathing and showering, assist with planning, assist with the planning of consistent daily routine, observe the home environment for safety hazards during every visit, perform the initial assessment to establish baseline behaviors and abilities in ADLs, instruct home health aide on ways to increase patient independence, administer medication and document and report efficacy and side effects, evaluate family members' response to support group and other resources, and listen to and acknowledge the patient's expression of feelings. So we'll go back to the top. So, can the LPN monitor abilities to perform ADLs? Yes. All right. Can the LPN encourage family members to express concerns? Yes. All right. Can the LPN assist the patient with bathing and showering on scheduled days? They can, but is that their scope of practice? No. Okay. Can they assist with the planning of a consistent daily schedule? Okay. Can they observe the home environment for safety hazards during every visit? Can they perform the initial assessment to establish baseline behaviors and abilities in ADLs? No. All right. Can they instruct the home health aide on ways to increase patient independence? Yes. Administer medications and document and report efficacy and side effects. Yes. Evaluate family members' response to support group and other resources. Do we evaluate independently? All right. And then listen to and acknowledge the patient's expression of feelings. All right. Let's see. How did we do? Good job. So yes, absolutely. The LPN can assist with planning routines, responsible for monitoring changes, observing for safety issues, and supervising APs, administering medications, and documenting reporting medication efficacy and side effects. All team members would be expected to encourage the family's expression of concerns and the patient feelings. The AP is assigned to assist with routine ADLs such as bathing, and then the RN would perform the initial intake assessment that includes baseline abilities and behaviors, and the RN is also responsible for evaluating response to interventions, right? So remember, yes, when we look at evaluating responses, remember that is not something that LPNs can do independently. You would collaborate with the RN, right, for evaluation. Good job. All right. The nurse works in a clinic that primarily serves older adults who have a variety of chronic health problems. While assessing patients, the nurse is vigilant for evidence of elder abuse, which is divided into 6 categories: physical abuse, psychological or emotional abuse, sexual abuse, neglect, abandonment, and exploitation. The nurse will use guidelines for documenting a sign or symptom. So, which type of elder abuse is depicted in each of the patient's situations? Note that all responses will be used and may be used more than once. Ugh. Okay, so I have bruises on my face, a black eye, and welts on upper arms because I fell down the stairs. What type of abuse?
Physical.
Physical. I give my oldest son money every week because he can't seem to get out of debt.
Psychological or emotional?
But won't that be like exploitation of her funds though? Like he's taking her money, so it would be like financial abuse.
Right.
'Cause he's like taking her money.
Okay.
Now he not taking it; she's giving it to him.
Emotional abuse though, because she feel bad if she don't give it to him, because that's her son.
Yeah, it could be,
Mhm.
but I don't know. That's kind of I don't know. Let's elaborate, y'all. Come on, Matthew and London. Let's put our heads together. I would say
Anybody else have any
exploitation.
insight?
Because emotional abuse is going to be like, you better not do this anymore. So now you're messing with their mental and then you're making them feel bad. But she's giving him her money to try to help him get out of debt when he probably be trying to buy some drugs. It's like, no.
I mean, or he could owe a bookie, and she don't want her son to get beat up. That's why.
Oh my gosh.
She'll feel bad, like if something happened to her son, like, oh my God, I could have helped him out with this money. And now look, emotional.
All right, we're gonna go with exploitation then on that one. Okay. I asked my daughter to go grocery shopping for me, but she hasn't gone for several weeks.
Would that be neglect?
Neglect.
That's what I was thinking, neglect.
Neglect. Okay. Let's see. My caregiver makes fun of me when I leak urine, so I try to clean myself.
That one's got to be psychological.
Psychological, emotional.
Okay. My lip got bruised when my caregiver was feeding me something that I don't like to eat.
Physical.
Say physical.
My daughter won't talk to me. She treats me like I'm not even there.
Abandonment.
Neglect. All right. My husband gives me some water before he goes to work. I don't drink that much.
Abandonment.
Abandonment.
Just
I
that-
don't like it when he does it to me, but he says that all people enjoy being touched.
Sexual abuse.
Sexual.
She left me at the bus station and gave me some money for a ticket.
Abandonment.
Abandonment.
Abandonment. All right, let's see. What did we miss? Okay. So, yep, physical abuse. I gave my oldest son money every week because he can't seem to get out of debt is exploitation. I asked my daughter to go grocery shopping, but she hasn't gone for several weeks, would be neglect. My caregiver makes fun of me is your emotional abuse, right? So we did that. Okay. And then my lip got bruised was physical abuse. My daughter won't talk to me. She treats me like there would be psychological or emotional abuse. I think that's the one that yeah, because we chose neglect for that one. Okay. Um, my husband gives me some water before he goes to work. I don't drink that much, would be neglect. I don't like him when he does it to me, but he says that all people enjoy being touched. Is your sexual abuse? And then she left me at the bus station and gave me some money for a ticket. Abandonment. All right.
On my husband one. Like, how is that neglect though? Because he left her with water.
Oh, I have to do it again. So let's see. Physical.
I'm guessing because like just leaving her with water, she's would be done with that 1 cup, and so it can lead to dehydration. So that'd be like a neglect, I believe.
What
But
would
she
we
said I
put?
don't drink that much though.
Let's see. I don't remember what we okay. Let's see. What does it say? Oh, we got them right now, but okay, so husband given water. Let's see what it says. Um, so examples of neglect include
Yeah, it
lack
said
of food
lack
and
of food and
fluids, poor hygiene, or
fluids.
unsafe living conditions. So I guess just because he only gives her like a small amount or a little bit of water, I guess, before he goes to work. All right. The nurse is interviewing a new patient at the bariatric clinic. Her the vital signs are temperature 98.6, pulse 88, regular respirations 20, excuse me, blood pressure 150 over 88, O2 sats 98 on room air, BMI is 30. She has a history of type 2 diabetes and hypertension, for which she takes metformin and lisinopril. She is here today to discuss weight loss options. Which questions are applicable for the nurse to ask when gathering data related to factors that cause obesity? So, what are we going to ask about factors that cause obesity? So would we ask about her diet? Yeah. Would we ask about exercise? Would we ask about work? No, no,
No.
yes, no. Do we snore or wake up suddenly in the night?
Mm,
Oh, you can come back. Do we feel fatigued or have an increased sensitivity to cold?
no.
Do we have a family history of obesity?
Yes.
Any back or joint pain?
Yes.
Do you often feel overwhelmed or stressed?
No.
All right, so what questions are applicable for the nurse assessment when gathering data related to factors that cause obesity? So we got the diet, we got exercise. We don't want to ask about work or snoring. Um, we don't want to ask about fatigue or increased sensitivity to cold or feeling overwhelmed or stressed. Is that correct? Before I hit submit. Da-da-da. All right. So, causes of obesity are high calorie, high fat diet, lack of exercise, and sedentary work or lifestyle. So we would want to ask about the work because maybe she sits behind a desk all day, right? Or doesn't do any, doesn't get up. And a possible genetic predisposition. Feeling fatigued or increased sensitivity to cold, right? That could be related to hypothyroidism as a possible cause of obesity. Um, and then feeling overwhelmed or stressed. So remember, not everybody, but a lot of people, if they are overwhelmed or stressed, they may overeat, right? So that's something that we need to ask about as well. Not everybody, but some people when they get stressed, right, they tend to eat rather than not pay attention to what they're doing. All right. So this will be the last one. So the nurse in the ED is assigned a 38-year-old patient whose symptoms include nausea, vomiting, diarrhea, and abdominal discomfort for the last 3 days after attending a weekend music festival. Vital signs are 100 degrees Fahrenheit, pulse 110, regular, respirations are 20, blood pressure is 90 over 70, O2 sats are 96 on room air, poor skin turgor. She states that she is no longer nauseated and has not vomited for 24 hours, but the diarrhea continues. She reports a headache and she is allergic to penicillin. All right, so she went to a weekend music festival and she's had the nausea, vomiting, diarrhea, and abdominal discomfort for 3 days. Not vomiting anymore, but she still has diarrhea, headache. So, for each healthcare provider order, indicate whether it is indicated, non-essential, or contraindicated. So, NPO, would that be indicated, non-essential, or contraindicated?
Indicated.
Indicated? All right. Give small amounts of electrolyte solution.
Indicated.
Indicated.
All right. Ibuprofen 800 milligrams by mouth for headache.
Indicated.
Oxygen at 2 liters per minute via nasal cannula.
That's probably non-essential.
Oops, non-essential. Oops. All right. I'll have to move that in a minute. Normal saline IV at 250 mLs per hour. Indicated, non-essential, or contraindicated.
I would say contraindicated.
Okay. Stool for culture and sensitivity. Indicated, non-essential, or contraindicated.
Indicated.
CBC.
I would say indicated.
Amoxicillin 500 milligrams by mouth 3 times a day.
Contraindicated.
Contraindicated.
And famotidine 10 milligrams by mouth.
Indicated because she's nauseated.
All right, let's see. All right.
Hey.
So if the patient's not vomited for 24 hours, it's no longer necessary to keep them NPO. So instead, we're going to give small amounts of electrolyte solutions such as Pedialyte so the patient doesn't become dehydrated. Oops. Ibuprofen is contraindicated due to the negative effects of NSAIDs on the stomach. O2 is within normal limits, so we don't need to give oxygen. An IV for hydration is indicated. The patient displays signs of dehydration as evidenced by increased pulse, lowered blood pressure, and poor skin turgor. So we'll do a CBC and a stool sample. And then amoxicillin is contraindicated because the patient is allergic to penicillin. And then famotidine we can give, right, to decrease the hydrochloric acid. All right, good job. You guys are doing good. Do these help at all? They are helpful. Okay, good. I just want to make sure they're helpful. But that is it. You guys have a wonderful week, and I will see you next Monday. Have a great week.
Miss Martin.